welcome. This is Senator Ben Cardin, and welcome you to Facebook Live, where I, on a weekly basis, try to get an expert in regards to COVID-19 to answer questions that you might have in regards to how we are dealing with COVID-19. And I'm very pleased today to be joined by Dr. Jennifer Nuzzo, who is the senior fellow at the associate professor at the Johns Hopkins Center for Health Security. It's good to have an expert here who can help us. And Dr. Nuzzo, I want to start, if I might, in the fact that now in all 50 states, we are seeing a reopening of our community. The question that's often asked to me, is it safe? Are we doing the right thing? Are we too slow or too fast? What is the game plan for reopening our community when we don't have a vaccine, do not have an effective therapeutic drug? So we know that there is community transmission, but yet we know we can't stay at home forever. So what is the game plan? What is the public health officials telling us is the right way to try to reopen society before we have a vaccine or an effective therapeutic drug?
Right. Well, thank you so much, Senator, for having me. And on that particular point, I think it's important for us to remember that the risk posed by this virus hasn't changed since before we all retreated to our homes. So as communities are reopening, it's important for us to remember that we still have to take protective actions as individuals to limit our chances of becoming infected. So that means still maintaining social distance, and still, if you're in a high risk group, potentially trying to limit how much you go out. Those individual actions are still important even as communities are reopening. But what we have done with the social distancing measures that have been put in place all across the country for the most part has been to slow that rapid acceleration in the growth of cases that we saw in in mid-March and early April. They've had, I think, an important impact. And now as we are seeing smaller numbers of cases occurring in many places, we're going to have to take precautions because those measures didn't cure the virus. They didn't make the virus go away. They just slowed the spread of it. But as we go back to life out of our homes, there's still very much the risk that the virus could start spreading more quickly again. And for public health officials, what that will mean is that they're going to have to do all those public health measures that we usually take to slow the spread of a virus. We have to test people and find who's infected, make sure they stay home and isolate themselves. Probably going to have to do contact tracing, meaning figuring out everybody who may have been exposed to those cases and let them know so that they can stay home until we know for sure they're not infected themselves. And those sort of case-based measures, those precision public health tools are what we're very much going to have to rely on now as we think about leaving our homes and trying to reopen parts of our communities.
So get to something that have been asked. Kathy asks, to date, 3.28% of Maryland's population has been tested. What percentage of Maryland population should be tested for either the active virus or antibodies to estimate a true infection rate and calculate the current mortality rate? Do we have enough test component supplies to do that?
So I put less emphasis on what proportion of the population is tested because in each state it will differ depending on how much infection we think is in the state. What I look at mostly these days is the proportion of tests that are being conducted that come back positive. We call that positivity. Ideally, you want the positivity to be small, because if it's not small, then that means that we're probably only testing the sickest of the sick and not casting a wide enough net to find infected people. And if we're not casting a wide net, that means that people who maybe aren't as sick enough to show up at a hospital and be tested, they're still out there and they're still transmitting. And that means we're missing opportunities to isolate those people, count them as cases, and do the contact tracing. So in Maryland and many other states, the percentage of tests that are coming back positive is still quite high, and we have to continue to work on expanding testing in order to get that positivity down. To me, that's a more, I think, important and probably public health driven metric than what proportion of the population has been tested. Because if I were tested today, I might be negative, but I could be tested again tomorrow and be positive. So just because you've been tested once doesn't mean that you're necessarily safe for the months to come.
So I just want to give a shout out to Johns Hopkins. Johns Hopkins, the numbers that they have been using are now used globally. They are considered to be the best source for reliable information on the number of people that are infected, that have been demonstrated to be infected by the coronavirus, as well as those that have lost their life. And those numbers have been pretty much relied upon, not only in the United States, but around the world. I also want to give a shout out to Hopkins for its work on developing testing. Was out there early, developing a more timely test, a more reliable test, and making that available in a more public way, certainly much more public than the public health facilities. So it was a real contribution to our community as well as to our country. I also need to acknowledge that Maryland institutions have done an incredible job. University of Maryland is out there in the forefront in developing a vaccine. They have been really out in the front of the COVID-19 issues. NIH, of course, does incredible research work, also located in Maryland. So Maryland institutions have been in the forefront in regards to COVID-19. But I think that the question that Kathy asked is a valid one.
Yeah.
You're getting such a high percentage of people who test positive,
Mhm.
taking a more infected group than would be the normal demographics. Does that indicate that the numbers are actually a lot higher than what we are presenting on the daily reports?
Yeah, so that's one of our concerns, and it's why we actually started at Johns Hopkins the Testing Insights Initiative to track testing as a way to understand the cases that are being reported. Because the way we find cases is through testing. So somebody gets sick and they go see a healthcare provider and they get a test, and if it comes back positive, they get counted as a case. But if there are a lot of people who have symptoms and then don't get tested, or people who don't have symptoms but are infected and then don't get tested, they're not going to be counted as a case. So in order to understand how much of the infected population the case numbers represent, we have to, in part, understand how states and countries are testing. And what we have found is that, as the US has worked to expand testing, the positivity, the percentage of total tests that are positive has fallen, which is good news, but there's still work to be done. And when a state, for instance, has a proportion of its tests that come back positive that's high, it probably means that they're casting a fairly narrow net in order to find cases, and that there may be a lot of people out there who are infected who maybe aren't sick enough to show up at a healthcare facility. And the reason why we want to know this is because if they're out there, they can still transmit their infection, and we want to find out who they are and make sure they get tested and make sure they are isolated, and then we can take all those other public health measures that we need to do. The question, I think, also asked about how we estimate the proportion of the population who has become infected. And that's a really difficult thing to do, particularly if we just look at our case numbers. In part because we're not testing everybody, so we don't really know what the denominator is. There will probably be studies conducted, hopefully here in Maryland, I don't know, but certainly in other parts of the country, and I would hope that there would be a national study to do this that could look for evidence of antibodies. And you've probably heard about serology tests, and what serology tests may be able to tell us is whether or not people were exposed to the virus in the past. And if we can do studies in a way that are representative of a population, we might be able to estimate from the results of those studies what proportion of the population may have already been exposed or likely infected in the past, which will give us more insights into how many people may have truly gotten this disease. But it's really hard to estimate that in real time as the case numbers are coming in. We almost always have to look backwards in order to figure that out.
So how are these we've heard may not.
Yeah, so a challenge with the serology tests in particular is that because they're not being used to diagnose who is infected and who isn't, they have not gone through the same regulatory scrutiny as the tests that are looking for the virus. And so there have been concerns about how reliable the test results are from the serology tests. The CDC and NIH and FDA are currently studying them to see how reliable they are. But some independent researchers have looked at some of the tests that are on the market and have raised concerns that they actually may not be giving accurate results. So for people who go out and want to get serology tests, you just have to understand that we don't fully understand what the results of those tests are going to tell us. We should certainly not infer that if we get a positive test result, that means we're completely protected from the virus. Because first of all, scientifically, we don't even know that having a positive test result does mean that you're immune from the virus. And also, we're not entirely sure how well these tests are performing and whether they're giving accurate results.
I want to ask you, we know that we've heard some of the professional sports teams are contemplating reopening and that they'll do regular tests to see whether the virus is among their players. Well, we have a lot of facilities that would like to open. We have daycare centers, we have schools, we have we have workplaces where we don't do regular testing because we don't have the capacity for regular testing. You've indicated testing is only as valid as the day you do the test, but it does tell you where the virus is located. And if you're trying to reopen a facility safely, whether it's a professional sports team, or whether it's a school, or whether it's a workplace, it's good to know that it is virus-free, or at least we believe it's virus-free. So we do not have the capacity to do widespread testing today outside protocols of the frontline healthcare workers, those that have symptoms, and then high-risk locations such as nursing homes. So what is the ethical answer here, or how do you go about doing this?
Right. So I'm not an ethicist, I'm an epidemiologist, but I'll give you my epidemiologist take on this, which is, you know, I'm a little bit skeptical about just testing broadly absent either symptoms or any particular risk factor, epidemiologic risk factor. So first of all, no test is perfect, and you can get, in particular with some of these tests, you might have false negative test results. So while it makes sense that anyone who has symptoms that's consistent with COVID-19 to be tested, and it also makes sense that anyone who has been exposed to a known COVID-19 case potentially to be tested, particularly if they develop symptoms. I think it also makes sense that people who are in very high risk professions, such as high exposure risk professions like potentially health workers or other frontline workers, and then in high risk settings like nursing homes and long-term care environments where we're really concerned not only about their exposure, but what the consequences could be if an infection, if the virus were introduced and spread in those facilities. But outside of those groups, I'm kind of concerned about doing routine testing on a daily basis, in part because I worry that it could give a false sense of security. You likely heard, you know, the White House has been testing people daily in an effort to protect, you know, the president and the vice president, which, you know, is I think a thoughtful exercise, but nothing is perfect, and there now have been cases. And so just because we have a negative test result, we shouldn't completely assume that that means everybody is safe, that means that it is risk-free. And the kind of more you do these tests, the more you would be worried about the potential for you know, false negative in particular test results. So I don't think absent those very high risk groups that just regular testing daily is a particularly you know, sound approach.
So we have here about whether we have enough supply to do an adequate number. We know we're only as strong as the weakest point of the supply chain there that do testing. And it seems like reagents is the area where we've had the lowest amount of supplies. Swabs were short supply. That seems to be getting a little bit better. And then we have the test kits themselves, or the media transcript, where you transmit the sample. So, what do you think we have an adequate amount of capacity to do testing here in Maryland, or should we have a greater capacity in order to be able to respond to where we are today or where we might be tomorrow?
So, I think Maryland, I think there have been some promising signs of, that Maryland will be able to further expand its testing. I know new providers are coming online, providing more options for people who want to get tested. I think the move to lift the requirement that people have a doctor's prescription in order to get testing, I think that will happen. My understanding is that there still are some kind of supply constraints, at least in some places, and so we'll have to further examine that. I think reagents remains a challenge for much of the country, and when that when other states are having problems, that makes it hard for every state because they're essentially competing against each other to gain access to these supplies. So I do think that while we've made a lot of progress, there still is more work to be done across the U.S. to not only expand testing now, but to make sure we maintain the ability to do testing at the levels that we will need to do. And as we head into the flu season, we will have to be doubly concerned about the level of testing and our capacities and whether we have all the resources we need to do it, because then we'll be dealing with two respiratory diseases that look somewhat similar in the beginning, and we'll need to rely on testing to help us sort out who has what.
So on supply chain, questions been asked how we should handle that. And I'm going to give you my view and then get your take on this. I think there should have been a stronger national policy on developing the domestic capacity to deal with the testing needs. The president did use the Defense Act to deal with swabs, but he did not use it to deal with reagents. And the National Defense Act was passed, Production Act, to make sure we had adequate domestic production to deal with our national security. And as you said, the competition among states, I'm not sure that's the healthiest thing for our country. We've heard that some of the supply routes were actually interfered with because of competition among states and the federal government. So there does not seem to be a national direction as to what is the adequate number of tests that you need to have in your community and how you can get the capacity to deal with it today and as we move forward. Because we don't know what's going to happen. This disease is certainly not a predictable disease. We don't have enough data yet to know how it's going to react during the summer months and what happens in the fall, and do we get a second wave, and what happens during the next flu season. And we need to have the capacity built up here to deal with it. I was on a call today through staff with the regional director from FEMA, Region 3. And one of the questions we asked is that as part of disaster relief help, we also deal with mitigation in the future. And Governor Hogan has requested help from the federal government to deal with mitigation. How are we going to deal with the next round of problems that we get? And are we going to be adequately prepared? So I hope one of the things we've learned from COVID-19, you need to have a stronger federal guidance and guarantee of supply routes so that we can have a national policy on testing and guarantee to all communities that have adequate supplies for that testing. Your view?
Yeah, so from an epidemiologic perspective, I think having a national policy on testing would be really helpful. I mean, one, because we look across all states and compare data, and if one state is having trouble and its neighbors aren't, that just means that those its neighbors still are vulnerable. So I think if our goal is to reopen and restore the economy, we need a situation in which 50 states and DC are as strong as they can be. And I don't think an ideal situation when you leave it to each state to sort of fend for itself in order to gain access to supplies. I mean, the challenge in pandemics is that every country is affected at once. And we know that the medical supply chain is limited. And essentially, we are not only having states that needing to, compete against each other, but also every other country in the world is trying to obtain the exact same materials. So I think it's in our national best interest to have a single approach to obtaining supplies. If that means negotiating with other countries where these supplies are made, that's fine. I think efforts to produce these things domestically are also important. But I don't think we will restore the economy or restore our public health protection unless we get to a point where every part of the country has what it needs in order to manage this resource, this pandemic.
So let's get back to the of our community. Pamela from Howard County asked, Governor Hogan is allowing counties to reopen only if specific criteria have already been met. Multiple counties have already announced in some way that they will not be reopening yet until they have met the criteria. How will these rules be enforced? How will county residents know that their county has been open once the criteria has been met? And this really raises a couple of questions Pamela's raising. First, who makes this decision to reopen and what is the criteria? We thought in April, when the CDC came out with certain guidelines on reopening that the president announced during a press conference, that was going to be the national standard, that you had to go a certain number of weeks to see a decline in your numbers before you started reopening, and then there would be a tier approach. The federal government sort of walked back on that as a requirement, throwing it to the states. Some states responded one way, some states responded another way. And then the governor of Maryland announced his plan, but then said the counties could operate differently. And several counties have acted differently than what the governor's direction was for the state. So there is a state of confusion here. From the way that you are seeing this now, are there standards that should be met before we reopen? And do we have a system in place that will allow that protocol to be followed?
Yeah, so public health experts have, laid out, I think, the public health criteria that need to be met for places to reopen. And as we said in an earlier portion of this, most states are opening in some cases, regardless of whether the criteria are met. I think, though this can cause a lot of confusion, I think the overarching message that should be made clear is that for individuals who are interested in protecting themselves, their families, and their loved ones, the need to take individual protective actions is still there. The need to try to avoid crowds and to maintain distance, particularly from people, people who are outside of your household, that still remains. This virus has not left us, even if we've decided to open public spaces again. And so particularly for people who are, in high-risk groups, their need to protect themselves and to avoid crowds and to avoid opportunities for exposure remains. So regardless of if a county or state is open or not, people still need to take those kind of actions to reduce the probability that they or their loved ones will become infected. But, I think when we talk about opening, that suggests, we've entered a new phase and we will stay there. And I think most people, when we talk about this, we think about it as a process whereby we continually look at data and we try to see, is this okay? What are the impacts of these decisions on the data? And if the data are becoming problematic, then a course correction is needed. And in part, the decision of whether to open, but also whether to stay open, has to be made based on what kind of public health resources exist in a community. So in a community that is being very aggressive at finding a lot of cases and isolating them and doing contact tracing, and they're keeping their case numbers down, that is great. And that really helps to reduce risk to the people who live in that community. So that's potentially things that aren't necessarily factored into a decision or not to reopen, but very much has to be monitored once the community is open.
So we have a question from Paul from Elkridge, which talks about a related problem. He says, how about mental health issues resulting from perpetual unemployment and demise of independent businesses? what can be done to ensure people get the help that they need?
Yeah, so this is, I think, a very worrisome and an important consideration. And, all of what we have gone through has had enormous consequences for all of us, but, in particular, people who have lost loved ones or have seen things the frontline workers who have really put themselves at risk on our behalf. And so I think we should be very mindful of mental health in addition to, thinking about the virus and the risk that it poses. And I would just, encourage people who are feeling like they're struggling. I mean, first of all, that's a very understandable thing, but to really, speak to a healthcare provider about being connected to resources to help with that, because these are extraordinary times, and the effects are clearly profound.
So to give an update, we of course have passed the CARES Act, we passed that several weeks ago. The CARES Act provides additional resources for mental health. It also expands greatly telehealth. And in mental health, we're finding that the use of telehealth has been a real godsend, that finding major advancements being made. So we have also tried to remove the obstacles to doing telehealth. And that's making it easier for individuals to get timely intervention from healthcare professionals.
That's great.
We also have provided additional resources directly because there's no question, not only the pressure that's raised by not being able to work or the pressures being raised by the financial impact, we're also in a much more confined environment now can cause challenges from the point of view of mental health. So for all those, addiction, by the way, is also significant increases. Domestic abuse, we're seeing all these issues are increases. So we recognize that. The House just recently passed what's known as the HEROES Act, which would be the next chapter in the federal response to COVID-19. The first three bills we passed, it's actually four bills because we replenished funds for the CARES Act. The first three bills were $2.8 trillion of help. Part went to state and local government, part went to individual relief, part went to businesses, and a significant part went to what we call the Marshall Plan for healthcare to provide funds to deal with the COVID-19 crisis. So mental health is clearly on our agenda. There's a group of senators who have got together to make it clear we're not going to leave this out of any additional packages. And we're also looking at it very closely in regards to the FY21 appropriation by the federal government. So we recognize that the strain has been pretty heavy on this. The other point I would raise is that you can reopen, but will people actually go out?
Mm-hmm.
You have a fear factor, particularly if you feel that you're vulnerable. Are you going to really go out and enjoy the type of climate we had prior to COVID-19? We hope that we will return to that day, but it will probably take a vaccine before we get full return to the type of that we saw before COVID-19. So these are just some issues that we're going to all have to be patient about because it's going to take some time to get to where we need to, but we're going to make sure that the services are available to take care of individual needs. We have Charlotte, who's written about seniors who live in senior communities, about being tested or what are we doing about that. You look at the numbers and you see that 53% of the state's COVID-19 deaths are related to senior living. So we know that's the highest single risk. What would you, I know we have the strike force that set off for our senior centers, mandatory testing. I don't know if you know the current status as to whether we're doing testing in all the senior centers or the nursing homes, but should we be spending more of our resources dealing with these communal living facilities?
Yeah, I think this is absolutely critical. And this isn't just a Maryland problem. This is a problem across the nation. I think nationally, nursing homes and long-term care facilities account for about a third of the deaths across the nation. And in some states, it's, over 60% of deaths are result from nursing homes. So this is a particularly vulnerable group that I think warrants special attention. And I think the decision to transit, to go to universal testing at these facilities is a good one. I think it's still coming online, but this will be absolutely critical because, if we just wait for an outbreak to occur, chances are that's too late. Once the virus gets into these facilities, it can transmit very, very quickly because the staff have very close contact with the very vulnerable residents that live in these facilities. It's very hard to maintain social, physical distancing in these facilities. Staff move between different facilities in the course of their employment. So the virus can spread very, very quickly. So efforts to prevent the introduction of the virus to a facility are critical. And it's been very tough for these facilities. They haven't had the kind of personal protective equipment that they need, and they haven't had, broad access to testing. But I think as those issues have gotten better, I think it'll be much easier for them to try to protect their residents. And so making sure that each of the facilities, not just in this state, but really every state, have the personal protective equipment that they need to keep their residents and staff safe, and to do universal testing so that if someone is infected and may not have symptoms, we can find that out as quickly as possible so that those people can be isolated before it can spread further.
My guest is Dr. Nuzzo, who is the senior scholar at the Johns Hopkins Center for Health Security, and we really appreciate your expertise in this area. I'm trying to get to as many of these questions, and they're coming in pretty rapidly. So let me return to testing one more time. Angela asked the question, when will antibody testing be available for all people who had symptoms in February and March and who at the time didn't meet CDC's criteria for COVID-19 testing, but were negative for the flu?
So my understanding is that these antibody tests are becoming increasingly available across the country, but also here in Maryland. The challenge, though, is how they perform and whether they give the answer that means something. And from my perspective, until I see the kind of study that the CDC and NIH and FDA are working on to evaluate these tests, the utility of them are a bit limited. I want to know that they're going to give really accurate results in order to, trust them. That said, even if we find that these tests are giving the right results, it's important for people to understand how to interpret the results. So if you get a positive, and that gives you indication that you may have been exposed to the virus in the past. But what we don't yet know is whether or not that means that you are protected now from the virus going forward. I think most people believe that it's likely that you will have some protection for some time, but it may be hard to discern from the test results whether that's the case. So people shouldn't take it as a license to, relax or a license to let their guard down because we don't know for sure what the results from these tests mean.
We have a question for you. I'm going to sort of give background on it. One of the areas that I've worked on is small business to provide protection so that small businesses can get through this COVID-19 and still be viable, still be able to remain a viable business. Small businesses are the growth engine of America. That's where we create more jobs and more innovation, but they don't have the same resiliency of larger companies. So when you go through a pandemic or you go through an emergency, it's very difficult for them to be able to get back on their feet. That's why we passed the Economic Injury Disaster Loan Program under the Small Business Administration, the EIDL program, for small businesses. So if they're victims of a flood or a natural disaster, the Small Business Administration is there to provide the resources and capital so they can stay in business. And we used the EIDL program during the floods that we had in Ellicott City, and it really helped Main Street businesses. We have made small businesses eligible for disaster relief loans and grants as a result of COVID-19. But of course, we also passed the Paycheck Protection Program, which has gotten a lot more publicity, that provides hundreds of billions of dollars of relief for payroll and other related expenses. I say all that as background because we want to make sure that small businesses are there for a rebound of our economy, because they're going to figure out a way to deal with post-COVID-19. They're going to figure out a creative way to get business back going, get you interested in using their companies, even in a COVID concern environment. So the question you asked, could businesses open and allow a limited number of mask-loved people in at a time? You mentioned a little bit earlier that we're going to have to practice social distancing and do things differently as we reopen society. But is there a way that retail businesses and restaurants and other places can function in a post-COVID-19 world, even if we don't yet have a vaccine in place?
Yeah, I think that there very much is. I mean, listen, as individuals, we're going to take actions to protect ourselves. And obviously, people have to feel that going out is safe. And in part, I think making sure that the health authorities put out the best data possible so that everybody can truly understand what's happening in their communities, that will be really important. But as long as we are keeping the data in check and keeping the case numbers as low as possible through the kind of aggressive public health actions that we need, testing people and isolating them, contact tracing, then I think, it is reasonable to think about having certain businesses open and do so as safely as possible. We talk about going back to normal, but as you said, the normal that we once knew is not going to we're going to return to that state fully until we have a vaccine. But is it possible to return to a new normal? And I do think that that's the case. I mean, I have just been really impressed by the businesses that have been open, the kind of measures that they are taking to protect their staff and their customers. So where I live, there's a local coffee shop that figured out they can leave the door open so that nobody has to touch the door handle, and they've moved to a completely cashless transaction. They found out a way for people to order online and they can just come in and pick up their food and go. I mean, those really kind of creative approaches to minimize exposure, I think, are great, and I'm really encouraging of it. And the more that we can do that allow people to patronize these businesses in a safe way, I think that'll be better for everybody, including our communities that rely on having these businesses. And so, I think some environments are lower risk than others, and I think businesses thinking very hard about what the risk is to their staff and customers is a really important part of thinking about how we can transition to a new normal.
So let's talk activities we're going to adjust, and that is voting. There is no more fun part of a democratic state than free and fair elections, where we want people to be able to participate without intimidation and be able to cast their votes. We have a very important election in Maryland on June 2nd, which is our primary election for President of the United States, U.S. Congress, and in Baltimore City for the mayor and city council of Baltimore. These are important elections, and of course, November, we're going to have a presidential election around the country. Traditionally, our voting is done at the precinct level, where most people go into a place that's relatively crowded. Sometimes we have long lines, congested locations, and pretty close contact between the person voting and the registrants that are getting the information down. So there's a lot of pretty close contact during that activity. Governor Hogan has changed the process with the strong support of local officials. And that is, we are now in Maryland going to be doing voting in a different way. So Monette asked, how will voting be conducted for elections? Well, Governor Hogan has indicated, as by executive order, has provided a way in which all registered voters will get a ballot in the mail that they can postmark and return by mail by June the 2nd, or they can drop off that marked ballot at one of the voting location boxes that are located throughout the community. Or if they haven't voted by election day by mail, then there will be a limited number of specific locations in your county where you can vote on election day, but it's not going to be the same voting places that you have traditionally gone to. So please check if you haven't voted by mail as to where the voting locations are. I say all that because that is different than we've seen before, but it does protect you from being in contact with a lot of people that are exercising their right to vote, some of whom may not be feeling very well that day, but if they had no other choice, that's the only way they could vote, they would very well have shown up at our voting place to vote and could very well infect other people. So I take it this is an example of what you're saying of trying to adjust to the new realities.
Yeah, we're trying to find ways to minimize people's exposure to each other beyond what's absolutely necessary, and to not just reduce the number of people that you come in contact with, but also how long you are in contact with people who are not in your household. So, kind of workarounds that reduce the number of contacts that you have and the duration of those contacts. That's the path to reducing risk from this virus.
So I'm going to continue with the next question, which deals with mortality rate. We hear this frequently, so let's try. And again, I acknowledge that we don't have really all the information we need to understand
Right.
the mortality rates
Yeah.
of COVID-19. But the question is, what is COVID-19 hype when the mortality rate is the same as the flu, pneumonia, according to CDC stats? Why didn't we shut down the whole state for Ebola, tuberculosis, known viral viruses that is transmitted via air?
First of all, I'll just say that one of the questions I get is whether we are overcounting deaths, and that just want to put it out there that we are not. When a confirmed death is reported, that means that somebody has been tested. So we are very much not overcounting deaths. It is possible that we are actually undercounting deaths because not every death due to COVID-19 likely gets tested before it occurs. And this is typical in sort of an outbreak scenario that, afterwards, when you go back and you kind of look at the medical examiner's records and you look at all of the deaths that were clinically suspicious, you may find additional deaths. And so it is likely that what we are seeing now is actually an undercount of the number of deaths due to COVID-19. That said, there's been a lot of comparisons between this virus and influenza. And I just want to point out that all of the deaths that we have seen, which have already exceeded that of most flu seasons, have happened in a very short period of time. Whereas an influenza season lasts for, from early fall to sometimes almost summer. So the fact that we've had this many deaths in such a short period of time is deeply worrisome. But also, when we calculate how many deaths are due to influenza, we do that again retrospectively, where we go and look for not just the confirmed influenza deaths, but also the people who had pneumonia that during the flu season that was likely also attributed to flu. So those numbers don't get tallied up until after the whole flu season is over. And so it's not really appropriate to compare what we are reporting now in terms of COVID-19 deaths to a kind of look back of a particular flu season. That said, we are very much on par to exceed all of the deaths that have occurred from any particular recent flu season. And another way that we can also look at this is what the excess mortality, so the number of deaths, just total deaths, not just COVID deaths, but total deaths that have occurred in this time period above what we would normally see for this time period in other years. And we have far exceeded that as well. So there are many different indications suggesting that we are not making overblowing this issue in terms of the public health impacts that it is having. Now, one thing that we don't know, and this is, I think it's still the open question, is what proportion of people who are infected ultimately die. Right now, what we are able to do is calculate what proportion of the cases die. And so you'll hear people talk about what the case fatality is versus the infection fatality ratio. And those will take studies, but I think when it all shakes out, this will, there's really no doubt that this is much more of a severe situation than a typical flu. And as for the other examples, Ebola, we don't have Ebola death. We had one Ebola death in the U.S. So, I mean, they're not really even, the comparison is very much mismatched.
So Barbara, interesting question. I'm concerned there won't be enough flu in autumn. Count on there being available. As I suppose people know, the shot that you can get, and it varies every year.
Right.
Virus. What will be the attention paid for the annual flu versus COVID-19?
So I think there's going to be a lot of attention on annual flu, seasonal flu. A flu shot every year is important, but it's particularly important this year because getting the flu shot can greatly reduce your chances of being hospitalized. And the more people we can keep out of the hospital come the fall, the better. The fewer flu patients that healthcare providers have to see while also having to see COVID-19 patients, the better. So I believe, I mean, public health officials are deeply worried about the flu. And so I think you're going to see a very strong emphasis on flu prevention headed into flu season because we very much don't want to have to deal with two serious viruses at once. And fortunately, we have a tool to address flu, which is a vaccine. And so if you've ever been on the fence about getting the flu vaccine or maybe in the past you have thought that you didn't need it. I'm telling you, this year in particular, you need it because the last thing you want to be doing is showing up into a hospital in the midst of having to deal with COVID-19.
And of course, the flu start in the fall, and therefore the shot vaccine will be available in the fall. And we are optimistic that we may get a vaccine early in 2021. So we won't have a vaccine in time for the flu season. And therefore, it's even more important from the flu, as you said, so you're not into that mix in the event that COVID-19 is still being spread in our community. It also would reduce the number of people who we get tested, et cetera, if we had this under control on the flu season. A very important point. We do have an interesting question from Kathy, and she's basically saying, what entity is responsible for advising businesses for the procedures they need to take to protect their employees and customers when they reopen? I'm confused about this. Do we know what guidelines they follow?
Yeah, I don't know. I mean, I've seen various different guidelines out there. Our center, the Center for Health Security, has issued some reports just trying to put forth the public health principles that businesses can consider in thinking about the risks in their facilities and what it means for their staff and their customers. But in terms of like here in Maryland, who advises them, I'm not sure I know, but I will just say in just the conversations that I've had with various parts of business communities, I've been incredibly impressed by how thoughtful they have been in trying to sort through the science and trying to make decisions about how to protect their employees and their customers. And, I mean, they're having to do this in not a data-free zone, but, there are not clear answers in many cases, and they're just trying to sort through it in, I think, a very rational and thoughtful way. So I really do give a lot of kudos to the business community for kind of stepping up and really participating in this pandemic in a way that I think is productive and is helping to keep communities safe.
So advice is distancing 6 feet is what is generally thought to be certainly indoors no closer than 6 feet. Outdoors is better than indoors. Coverings are important. And if you are not well, you should not be with other people. So you should be home. I think they're the common types of advice given to all of us, so that if you are in a retail business, you want to set up your business in a way that you can do as much as you can outdoors. That's why curbside pickup is encouraged. If someone comes into your place, you want to make sure they're wearing face coverings as you are wearing a face covering in order to protect other people. And you certainly want to keep distancing where at all possible. So they're just the general advice, but I think Kathy's question is really very valid. As we get to more of our businesses opening up, you're going to need clear directions. So let me get to the question that is asked more than any other question. And that is, are our children going to be back in school in the fall? And if they are, how are we going to protect them to make sure they're safe?
So I don't know if that decision will be made to open schools. I tell you, I'm a working mom with 2 young kids at home, and it's really tough. And they're suffering from not being in their regular routine and around their peers and teachers. So, but of course, this is a complicated decision. And there are still some unknowns. I would say, on balance, compared to other populations, there are few children reported among COVID-19 cases, and there's some evidence to suggest that they may not transmit COVID-19 in the same way that they are responsible for transmitting influenza. So for influenza, children are particularly at risk for severe illness, and they are also primary drivers of disease spread. And so far, that doesn't seem to be the case for COVID-19. So there's some encouraging signs there. That said, probably everybody is following the kind of newer stories about this multi-system organ failure syndrome that some pediatric patients are experiencing. And it's not yet known fully if it's tied to COVID-19, but it seems people are concerned that it might be. And so, studies are ongoing to try to understand what is causing that. It is, I will say, though you're hearing reports of it, the numbers are still very small. So it's still a very rare phenomenon. But obviously, all of this has to be taken into account as people are considering to open schools or not. And in addition, I think we also have to consider the grown-ups in the schools and what their risks are. And so for people who are maybe over the age of 65 or have underlying health conditions, maybe being in these settings is not the best. And if there are alternative roles that they could play in education that don't involve exposure to a large number of people, that may be helpful. I do think that it would be nice to find a way to have kids be more educated in an in-person setting, because I'm speaking more as a mom who's trying to do e-learning at home, and it's really not easy and I think ideal in many circumstances. But I think there's still an open question on what the best approach is. So we'll see what happens.
Well, Van Hollen, several conversations. Our Board of Education attendance. Look, there's a risk. I agree with you. Our children need education, and it's a challenge just learning, particularly when we know that there is a gap in connectivity. That so many of our families do not have adequate internet high-speed connections. So, and even those that have it, it's a challenge for a lot of students. So, I am pleased to see creative planning being done by our school systems to take a look at staggered starting, to look at much larger use of classrooms with smaller number of students in it in order to have distancing within the classrooms themselves. They're talking about perhaps a certain number of days not actually being at school, but trying to do things in a way that can minimize the large concentration of students at one time being at the school. So they're looking at different ways to try to handle this. One of the things that we want to make sure is they have the financial ability to do this. And we did provide money under the CARES Act for our pre-K through 12 school systems. In Maryland, it was $240 million that became available to our 24 county school systems. And we know that there's additional funds involved in the HEROES Act, the bill I referred to a couple times, that has passed the House of Representatives, that I believe will be considered at some time in June by the United States Senate. We got to get our students up to speed, and part of that is to deal with the digital divide, deal with connectivity, and let's make sure that we invest in making sure that every family can get that type of service to their children. But it also is a safe way we need to reopen our schools so that children can get the benefits of our educational system. Risk reward. We're going to figure out some way to get it done. The good news is that the risk to the children might not be as great, but as you point out, that's not true for all children, and certainly not for adults. And then, by the way, those children do go to other homes. That's another reason for having testing. That's another reason for being able to identify if you have a problem. And it's another reason to make sure and encourage that if a child's not feeling well or has temperature, that child's not in the classroom. So there's a lot of things I think we can do to make it safe. And I know our school systems are planning on this, and I have confidence that we will see some progress. The last question I have is one that I'll ask because we're running out of time. Is from Gretel, who's basically asking, can you transmit the virus through the clothes that you wear? You know, we're all careful to wash our hands after we've been outdoors to make sure that we practice the hygiene on the germs. But should we be concerned about the clothes that we are wearing during our visit to the grocery store? Could that be a source of the virus entering our home?
So it's possible if somebody who's sick deposits virus on a surface and then you touch that surface and you touch your nose or eyes or mouth, or they deposit it, and that surface could be, clothing or something that you sit on. It is possible. I think it's probably a lower probability than being, in close conversation with somebody who is actively sick. That said, it's always a good idea to wash your hands. And if after you've been in a public place exposed to a lot of people, you want to change into different clothing, I think that's fine. But I don't personally get too worried about that compared to other things. I will say one thing. It's great that people are, wearing masks in public, particularly now that that's a requirement. I see a lot of people wearing gloves, and I actually do worry about gloves because I worry that you're touching surfaces and then it's on the gloves, and you're not going to be washing the gloves off. So I don't think gloves actually protect people in the way that they think. But certainly washing your hands is a great idea, and we should be doing this even when we're not in a pandemic.
Well, Dr. I'm so happy that you came from New York down to Maryland. We very much have your Dr. Nuzzo is the senior scholar, assistant professor at the Johns Hopkins Center for Health Security, and is very knowledgeable on this issue. It's been a real pleasure to have this discussion. I thank all of you for joining us on Facebook Live as we talked about the realities of reopening our community. We all know we need to reopen. We want to make sure it's done in a way that we do it as safely as possible. This virus is going to be with us for the foreseeable future. It is deadly. We've got to deal with it in a very serious manner. And there is a way that we can minimize the risk. And I think our conversation today has been very helpful in us understanding it. So I want to thank you all for viewing today. And again, thank Dr. Nuzzo for her contributions to this discussion and what she does every day to keep us safe.
Thank you, Senator. Thanks for having me.
Bye.
Bye.